Good morning. I'm Colin Murray Kemp, and this is Thrive, the Future of Healthcare. Today we will be talking with Dr. Jerome from Palmetto Proactive about strategies that he's implemented to increase patient volume or sustain patient volume throughout COVID-19. Welcome, Dr.
Thank you.
So just want to start a little bit, talk about the direct primary care model. How did you get into that, and how's it worked thus far through COVID?
Yeah, so the name of our practice is Palmetto Proactive Healthcare, and as you know, it's a direct primary care practice. And what is a direct primary care practice? Well, about 10 years ago, my co-founder and I realized that the system was complicated, the healthcare system, the way patients navigate through healthcare, office visits, hospital system, imaging was very, very complicated. We thought there has to be a simpler way, a more cost-effective way, a more accessible way to navigate the healthcare system. And so what we did is we kind of, if you're a foodie, you know the term deconstructed healthcare.
Sure.
So what we did is we put the patient in the room first, primarily in the room first. They're the most important person in this relationship. Then we put the doctor in the room. And what we did, we kicked out the insurance companies. We kicked out anybody else that didn't have anything to do with direct patient care. And by doing that, we were able to decrease costs by 50 to 70%. And so we started in 2010. One patient walked in our office the first week. We were elated that one person found our value, but then we were also scared that, heck, this isn't going to work out.
Right.
But then 10 years later, we have 4 clinics running. We have one on the way here in Mount Pleasant, and we're hoping to create another clinic in Somerville and other areas in the Low Country.
So you're in the upstate, the Midlands, and now the Low Country.
Yeah, our first clinic was in Spartanburg. Because I trained at Spartanburg Regional, and that's where I learned about, first of all, medicine, how to care for patients, and second of all, I had an interest in the business aspect of medicine and how much things, medical procedures, drugs, how much a patient encounter cost.
Sure. So
in my third year of residency, I was actually in the business office, and I looked at every line item. And I discovered that, in the hospital, there's a $25 aspirin. Everybody's heard that term, that story. And I also discovered that a mucus retention device was $40 during a hospital stay, and that was a box of Kleenex.
Yeah.
And so all of us have probably heard this story. Anybody in the healthcare arena have heard like all these elevated, exorbitant costs that are just that the patient doesn't realize until they get their bill.
Yeah.
And they almost kind of freak out and say, "What is this?"
Yeah, yeah.
And then another saying I have: if you need an explanation of benefits to explain your benefit, then that benefit probably isn't beneficial to you.
Sure.
So I think it's kind of crazy that a simple relationship between the physician and the patient has become this big monster machine that is surrounded with a lot of smoke and mirrors, and there's no clarity. And the biggest loser in this whole relationship is the person we're supposed to be caring for, and that's the patient.
Yeah.
And so what we did is we just streamlined it.
So you have this concept of people, process, purpose that we've spoken about before, and how does that kind of concept, how did it prepare you for the challenges that COVID-19 brought?
Yeah, so, like you said, our mission is our people, our process, and our purpose. So our people are our patient, our process is direct primary care, and our purpose is to reunite that patient and the physician in a proactive relationship. And how did that prepare us? We're built for this current scenario. 10 years ago, we were very, very intentional about how we're going to interact with patients and meet them where they're at. So that means, if you want to see us the same day or next day, or if you want to see us, call us after hours, we're available. And if me as a physician think we can interact between texts, I'll text you back. Yeah. Or if you think, hey, I need to see that rash on your child, we'll send pictures back and forth. Or if I need a video visit, because there's a lot of things you can tell with talking to a person. So whether it be, in person, in the clinic, same day or next day, whether it be a telephone call after hours or a texting, if appropriate. Personally, and our physicians like to take a telephone call first, because there's a lot of clinical value in somebody talking to me. So if you call in, you call me, and you're a known asthmatic, and you call and you can barely get 3 words out,
Yeah.
guess what? I call 911 on your behalf, where I tell you, hey, you need to have a loved one send you to bring you to the ER. But there's a lot to know from just a call. And then if appropriate, for example, as parents, oftentimes we go to text and we say, it's a lot of times about a childhood rash. And I said, send me a picture. And then we'll text over the rash. Or if needed, we can do a telemedicine visit. So that's how we meet them where they're at. We meet them at the playground.
Sure.
We meet them at their house.
So I want to get into a little bit more about telemedicine here in a little bit, but I know in direct primary care, the concept of active communication is really important to that style of practicing. And I wanted to ask you about how that concept of active communication has really helped you maintain your patient volume through this pandemic.
Yeah, so once again, we were very, very intentional about that patient in the room, and also now that patient where they're at. And so in a typical family practice, if I worked at a big hospital system X, a typical family doctor has 3,000 to 4,000 patients in their panel, and that's a lot of patients.
Sure.
In direct primary care, we limit our patient panel to 600 to 1,000.
Mm-hmm.
So the engagement, so our appointments are not 15 minutes, they can be 30 minutes, 45 minutes, an hour. Okay, so we can focus on that patient and know and allot time specifically for them. For example, blue collar Joe, sent there by his family because he has heart disease. He just wants to kind of go in and out. Tell me what I need to do, doc, to control my blood pressure, not to have a heart attack or stroke, and I'm on my way. Or somebody that's really dealing, especially in COVID times, we're seeing a lot of this depression and anxiety. And we really need to sit there and kind of walk through, what's causing their anxiety, whether it be work, whether it be, hey, I'm at home with people 24/7 that, I haven't been home with before, and it's getting, I actually had one visit recently that, I've never been in the same room with my fiance for that long because we both had separate lives until now, and I think I'm getting more anxious. So and that visit was longer, and we kind of walked through it and talked through everything. So
there's nobody regulating you, telling you how long you can spend with the patient.
Exactly, because our model isn't dependent on. In the medical field, there's something called RVUs, relative value units. So if you, Colin, came to visit me, and you had one problem. I get there's almost like a point system, and I get paid based on the interaction with you.
Yeah.
Whereas in direct primary care is a membership model. So it's almost like Netflix.
Mm-hmm.
So you pay me, X amount of dollars per month, and you get 24/7 access to me. That 24/7 access a lot of times scares physicians. The second person in the room was the physician. They're like, wow, they get 24/7 access to you, and they're picturing me texting patients all day and on the phone or emailing patients, but it's actually quite the opposite, because once again, we've been very intentional, and we know the pain points in the traditional system is 10-minute, 15-minute visits, get them out, see the next patient. But in this scenario, in direct primary care, I can spend as much time with them. So those calls about their kid's sore throat, strep throat, you don't get the call the next day about, hey, my kid's not better. They took one day of antibiotic and they're not better.
Yeah.
Because we educate the patient before they leave. Hey, this might take 2 or 3 days. In 2 or 3 days, call me if they're not better.
So how have your staff, and I want to ask you a little bit about what platforms you're using for telemedicine, and how have your doctor and staff, how's the functionality, the usability of it, and are they receptive to it?
Yeah, so once again, from the beginning, we were built for this scenario. So we use all platforms. That we have a diverse patient panel, anywhere from children to Medicare age. So within that panel, there are people who just want to pick up the phone.
Yeah.
And our mission is patient driven. So our staff is basically an extension of myself. So they know if they call, let's say for example Molly, who's in the Greenville office, they know she's an extension of me.
Yeah.
And so there are patients in a certain demographic, just say the older demographic, that like the phone calls.
Yeah.
But then there are patients probably in your demographic that rather just, text or email or call and get a message straight to the doctor
and that's
and
again the
that
concept of meeting the patient where they're at, right?
Exactly.
Yep.
And that it's beyond place. It's the technology.
Sure.
Yeah.
What sorts of sicknesses have you found that telemedicine is kind of best for?
Yeah, so I'd like to tell you as a physician, I like to tell you what it's not for.
Okay.
So and then I'll tell you what it's best for. So lacerations, of course. If their kid has a laceration, I can't do that telemedicine. Again, if somebody has abdominal pain, a child or an adult has abdominal pain, I need to push on the belly. I don't think any doctor would be comfortable to evaluate a child or an adult for those kind of things. Yeah. But it's good for, and I think it's great for relationship medicine. What our mission is driven for is to, like I said, reunite that patient and physician in a proactive relationship. I think it's best in this scenario because, again, for example, Colin, if you're a patient of mine and I've known you for months and you're an asthmatic, and I don't need to drag you into the hospital, into the clinic to see me.
Clinic.
I can follow up with you and say, hey, how are you doing? How's your breathing? Are you using your rescue inhaler? How many times are you using it a week? And we can kind of go through that.
Yeah.
And then I can send the prescription to the pharmacy.
Yeah.
Or my diabetics or my people with high blood pressure.
Continual kind of care.
Yes, continual kind of care. It's good for mental health.
Yeah.
But as a doctor, at least, every 6 months or every 12 months, I like the patient to come into the clinic so I can see them and listen to their heart and lungs, making sure that they're not hiding behind that screen, things that I can't see behind that screen, like their feet. I can see their feet, but I need to touch their feet to feel the pulses, and I actually need to, believe it or not, smell their, to see if there's any odor related to diabetic foot ulcers that I need, There's a lot of things in medicine that still have to be done in person, but telemedicine is a great extension of what we do in that patient engagement and building that trusting relationship with patients.
So for your patients, what kind of health issues have you seen, I guess, an uptick in since the pandemic began?
Yeah, and I think we discussed this earlier, probably one of our earlier conversations, what we did and did not do during the coronavirus when it was kind of ramping up. So one thing we decided early on is that, one, because we were worried that we wouldn't get enough personal protective equipment, and two, because all the testing was available for the big hospital systems, and we just didn't, and there was some anxiety and fear with our our staff regarding testing coronavirus. We decided we weren't going to test. Well, we decided the way we can best serve our community is by being an outlet for things that aren't coronavirus related. So what we saw an uptick in was, people were sent home, and guess what? People are going to Lowe's, people are going to Home Depot, and they were fixing their decks, painting, they were learning how to cook again. So we saw burns, we saw lacerations because they were learning how to cook, cuts, we saw sprains and backaches. So we saw all kinds of things, people falling off ladders, saw a few broken bones. So in the end, for those 2 months that we didn't test, we were very, very happy that we were an outlet for the community. So we were a safe place where we didn't see any coronavirus. We screened them, fever, body aches, diarrhea, loss of smell, been to a hot spot in the last 14 days. We would see them again at their place. We meet them. We would actually telemed car and say, hey, you meet the criteria to get tested. We would email them an order, and they would fall in line at one of the local hospitals. So we're doing it for free. Yep.
Gotcha. So we've talked a little bit about this kind of the success of your practice and the DPC model through COVID-19, and I just wanted to ask you a little bit. I mean, we're interviewing all these other physicians, and they're at 60%, 70% patient volume, and you've actually increased patient volume since March. I wanted to ask you a little bit about what you kind of thought played into that and how that happened.
Yeah, so in the past 6 months, our membership has actually increased 10%. And that we were pleasantly surprised. But we look back and we're like, well, it's understandable because people lost their jobs. So that means they lost their insurance. And one thing we don't, I guess I don't like to say we don't accept. We accept all patients. We just don't accept insurance. We don't file on their behalf. We have a lot of people come to our office that have insurance. We just don't file on their behalf. But the people that did lose their insurance or had a very, very high deductibles, guess what? They started searching because there was diabetics, people with hypertension, hypercholesterolemia, and other medical problems that needed care that were unemployed and didn't have health insurance. So they started searching and they found us. And what we're finding, those people are going back into the workplace and they're realizing, wow, this is a much better experience than what I had previously. And so even though they get their insurance back, we like I said, we have all comers, insurance, no insurance, underinsured, very high deductible, and they're realizing the experience is worth it. So it's worth that per member per month Netflix subscription.
Sure.
Yep.
So I think community outreach is a really important concept during this time, like local health literacy and community education. Has Palmetto Proactive, not necessarily just to your patient base, but to the community at whole, have y'all taken steps to work on health literacy during these times?
Yes, so we believe that healthcare is local, and that's why in Mount Pleasant, where we have a local physician that was getting burned out in her current workplace that decided, she reached out via email and said, I want to bring Palmetto Proactive Healthcare to the Low Country.
Sure.
And so regarding your question, we've been doing community outreach since the onset. We love our community, Spartanburg, South Carolina, in the upstate, and it's a good way for us to commit to our community. We put kind of like sponsorships.
Yep.
Palmetto Proactive sponsors the farmers market.
Sure.
It's a good way for us to kind of support the community and also market ourselves. And I think the community realizes that, we're just good guys and want what's best for our community. And our docs live in the community, and their kids go to schools in the community, we just like to be embedded in the community.
So you were talking in our pre-interview conversation, you were talking a little bit about the substantial increase over the last decade in this direct primary care model. And I wanted to kind of pose the question about the past, present, and future, and really how I'd love to tie it back into COVID-19 and even the kind of strategy to increase patient volume.
Yeah, so in the past, Dr. McCarthy and I worked in the traditional system, and like a lot of doctors, we got frustrated. So we looked for this outlet, direct primary care. And about 10 years ago, there were 25 of us in the nation, and we went to our annual direct primary care summit and met a lot of the early adopters. And currently, there are almost 2,000.
Wow!
And probably within the next month, there will be. I'm on a Facebook private kind of channel group of DPC doctors, and there are doctors announcing every week that they've thrown in the towel with the traditional system and are going to open their own direct primary care clinic. And so the future, I think this is going to be a viable option. I think we need some help, from the government. Not a lot, but some help to make the laws clear about direct primary care. That's another conversation, but we need help from them. But I think you're going to see more of these clinics. We're hoping to expand.
Just kind of lastly, remove the direct primary care concept. What is your message to independent doctors, healthcare administrators, healthcare leadership throughout sort of the Southeast and even the nation as to how best to approach this pandemic and sustain your patient volume and even increase patient volume? What's your message to the greater medical community?
Yeah, just be patient-centered. Focus first on the patient. I think a lot of times when things like this, once again, COVID being the catalyst, kind of throw our arms up. It's like, how do we fix the system? We focus more on the system instead of how do we get closer to the patient to care for the patient. So I think we just need to cut all the unneeded waste in the system, the things that we're doing as physicians, as administrators that really don't focus on the patient, the most important person in the room, which is the patient.
Sure.
Yep.
Sure. Well, thanks, Dr. Aya, for coming out and being part of Thrive, the
Thanks.
future of healthcare.
Appreciate it.